Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. I bid to the speaker and all participants. Before we begin our session, let us start with the recitation of Kitab Al-Fatihah. Dear all participants, please fill in the Google form for the star point via the link provided in the chat. And without further ado, I would like to invite our speaker for today, Dr. Uzair, to start the session.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I'm Uzair. I'm your senior, and I hope that this session will benefit for you guys. And let's make it less formal because every now and then we would know that eventually we will be a colleague and we will be working together, inshallah. So currently, I am waiting for my housemanship. So I've been called by the academic bureau from Maths to give a lecture or some input on pre-eclampsia and eclampsia. This would be a bread and butter for you guys, especially those who are in third year and fifth year. I guess this is a very important topic, and surely, I'm not saying 100% surely, but this will be a question that will be part of your professional examination, either in theory or clinical examination. So without further ado, I would like to share my screen. All right. Can you guys see the screen? Can you see my slide?
Yes.
Okay. So today I'll be talking about preeclampsia and eclampsia. Well, this slide I'll be sharing with you guys, but disclaimer, this is just your senior slides which I take and I review and I put some input from the NICE guideline and also CPG. And basically it's just a sharing. Um, your lecturer knows better, of course. Glad if you can see or meet Dr. Azhar or Dr. Famida, even Prof. Hamiza, to discuss more on this preeclampsia. I'm just a beginner, but I'll share what I know and what I've learned to you guys. So inshallah, that can be maybe not much, but still few to benefit you guys. So preeclampsia. Okay, so preeclampsia is defined as when you have hypertension. It's just a similar diagnosis of hypertension, whether it's in medical, ONG or surgery. We use the similar definition of hypertension, which is systolic blood pressure 140 millimeter mercury and 90 millimeter mercury. But what is the key point is when you have at least 300 milligram protein in 24 hours and it arising de novo, it means it's you never had before any hypertension. It's only occurring during the pregnancy, and it occurs after 20 weeks of pregnancy. So means if you have a case where at 12 weeks, 15 weeks, the patients already have hypertension. So this is not yet considered to be preeclampsia. So the patient already have a chronic hypertension before even starting the pregnancy. So it just the patient did not realize or did not screen or did not diagnose before to have hypertension, but accidentally during the pregnancy, she's actually is the occurrence of generalized convulsion, coma. in the setting where there is absence of preeclampsia, and it can be absence of other neurological conditions. So it can just only convulsion or a coma or visual disturbances alone. So yeah, it can be just like that. So, but when you go through the CPG Management of Hypertension 2018, there are sort of changes how we define preeclampsia. So if we look into 10 teachers alone, the preeclampsia as per the definition before, it just said that hypertension with proteinuria more than 300 milligram. But if you're looking on the CPG of hypertension, uh, we have a slight changes, which is you can have a preeclampsia without necessarily to have significant proteinuria. Means if you have hypertension with renal insufficiency, meaning your serum creatinine less than 90 micromole per liter or oliguria, so you can be diagnosed as preeclampsia. Raised transaminase, severe right upper quadrant epigastric pain, even you have convulsion, thrombocytopenia, coagulopathy, hemolysis, or even fetal growth restriction. Meaning to say, if you have a patient who came to you 24 weeks period of amenorrhea, only have hypertension, no proteinuria, nothing. But when you do ultrasound, you scan the baby have smaller than date. You see a growth restriction. So this is one of case definition. It falls into the case definition, which is this patient also have a preeclampsia. So the approach to preeclampsia and gestational hypertension is different, and I'll be explaining into that later. Okay, so this is risk factor of eclampsia. Why do we need to know about this risk factor? Because it changed our diagnosis, it changed how we see our patient, and of course it changed our management. So if patient have any of the high risk factor of eclampsia, we got to give the patient antiplatelet. We call them as preeclampsia prophylaxis. Low dose aspirin. If you go through the NICE guideline, you see 100 to 150 milligram of aspirin daily. So high risk includes patients who have chronic hypertension, chronic kidney disease, autoimmune disease, for example, SLE, antiphospholipid syndrome, type 1 or type 2 diabetes mellitus, or hypertension during the previous pregnancy. Not necessarily chronic hypertension, but if the patient have a history of gestational hypertension during previous pregnancy, so this patient includes in the high risk factor. So for moderate, those who are primary gravida, age more than 40, pregnancy interval more than 10 years, obese patient, family history of preeclampsia or multiple pregnancy. So any more than one moderate risk factor, you should consider to give the patient preeclampsia prophylaxis. Any high risk patient should be given the uh, preeclampsia prophylaxis. So this is the prophylactic therapy. So the aspirin is actually should be given at least less than 16 weeks, because the idea why you give aspirin, it belongs it's actually because of the pathophysiology of the preeclampsia itself, where preeclampsia happens due to poor invasion of the artery, the placenta blood vessel. So by giving aspirin, you actually inhibit some of the cytokines, for example, thromboxane and also the procyclin. So you should be given before the placenta is completed at 16 weeks. So yeah, that's why. But in our practice, in practice, if you go to the ward, you go to KK later on, if you have posting in klinik kesihatan, you will see that even if they are been diagnosed with preeclampsia at maybe 20 weeks, or after that, they make booking after that with risk but not yet diagnosed with any preeclampsia, they will still be given this prophylactic therapy. I'm not sure why, but you'll see, and if you got the chance to ask, you ask lah. Okay. And also, we should also give them a calcium, low dose calcium supplement. Okay, that should be commenced before 20 weeks gestation. Okay, this is severe preeclampsia. So any patient who have preeclampsia with any of these characteristic, it falls into severe preeclampsia. It has different management. Okay, so for example, systolic blood pressure more than 160 or diastolic blood pressure more than 110, patient have thrombocytopenia, abnormal liver enzymes, and usually elevated transaminases, severe persistent right hypochondrial pain, pulmonary edema, new onset of cerebral or visual disturbance such as scotoma. So this, if patient have this in regards to the hypertension that they have, they actually have a severe preeclampsia. So be careful. So when you have a patient with preeclampsia, what you have to do is, these are the investigation that the lecturer, the examiner will definitely ask you. It is included in the preeclampsia PE profile. We call it in the ward. So we have the PE profile chart. So if you have the chance to go to the ward later on, you can look for patient who have preeclampsia. They actually have the PE chart. We call them as PE chart because they have sort of a lot of investigation and a lot of things to be written on the PE chart. So one of it is full blood count, liver function test, renal profile, 24-hour urine protein, urine analysis, ultrasound scan, CTG if needed. So I'll just skim through the important one, like of course full blood count, liver function test. This is where you got your helper syndrome, and the renal profile. Basically, why you need a renal profile? Basically, first, you wanted to calculate the protein creatinine ratio. So if you go through the NICE guideline on hypertension in pregnancy, they wouldn't actually recommend you to diagnose preeclampsia using 24-hour urine protein. Because when patient comes to you and you suspect the patient have preeclampsia, don't you think it's a fussy to do like 24-hour urine protein? Because if I were to collect my urine myself for 24 hours, it's not gonna be, it's not really convenient, I would say. So the next guideline suggests that 24-hour urine protein is no longer routinely done because it can be replaced with protein creatinine ratio and also albumin creatinine ratio, because you did do the liver function test and renal profile, so you can easily calculate the protein creatinine and also the albumin creatinine then without having to wait for 24 hours and getting, and only then you got the diagnosis of preeclampsia. So it's long, it's and it cannot be done as outpatient. Patient has to be admitted for 24-hour urine protein. So urine analysis, you can give patient dipstick test, even can be given as outpatient. So patient uh, herself can like, oh, my urine protein is getting increase, and it's time to get back to the KK or the nearest hospital. Okay, ultrasound scan, because we have to survey for fetal growth restriction, IUGR, and also oligohydramnios. CTG, you can have fetal bradycardia. Uh, preeclampsia does not directly cause fetal bradycardia, but the treatment of preeclampsia, for example, labetalol, nifedipine, nifedipine is calcium channel blocker, and labetalol is beta blocker. So both of the medication, if we given to the mother, it can travel through the placenta to the fetal circulation and can cause fetal bradycardia. That's why you have to some sort of monitor if clinically indicated. So it's not every here and there, every single checkup you've got to do CTG. If you look into the NICE guideline, they have the specific indication why you have to do CTG. But I guess it's maybe it's too much lah untuk kita tahu satu-satu tu. I think it's too much. Just basically, I think it's already good enough if you know the basic investigation that we should actually do in our level. So this is basically fetal monitoring, what you would like to do. Okay, so different with gestational hypertension, fetal monitoring in those who have preeclampsia, you got to do every 2 weekly. Okay, setiap 2 minggu, every fortnightly, the patient have to come to the KK and do scan. So what we scan for is the fetal growth, the amniotic fluid volume, and also the umbilical artery Doppler. So why we do this? Because if the patient have IUGR, we either reverse diastolic flow or non or absent diastolic flow. So this patient required early delivery and it falls into IUGR. So IUGR is also a famous topic, but you got to read those because dia usually akan keluar lah waktu either final block exam or professional exam. Usually IUGR akan keluar. Okay, so what's the difference between gestational hypertension and preeclampsia? Okay, satu, by the definition alone, gestational hypertension when the patient only have hypertension. Preeclampsia came with the package. Dia mungkin ada protein, proteinuria, or other things that followed with preeclampsia. So its admission is required. So for gestational hypertension, if you only have hypertension without severe hypertension, admission rarely or usually patient is not admitted. Okay. Different case with preeclampsia. Pre preeclampsia, pre preeclampsia, preeclampsia usually patient is admitted if clinically indicated. Means you can have patient that slightly have some degree of hypertension, maybe 140/90 or 146/92, but with some clinical condition. For example, have severe headache, severe upper gastric pain. So this is where admission is indicated. Okay, so blood pressure monitoring is different with gestational hypertension. If we have a preeclampsia patient in the community where they go to the clinic kesihatan, they have to go to clinic kesihatan for at least 2 times in a week for blood pressure monitoring. But only gestational hypertension, only once a week is enough. So for blood investigation, preeclampsia patient require at least once per week blood investigation, for example, like the renal profile, the albumin, the liver function test that has to be done every once weekly. So for the fetal surveillance that I mentioned before, every 2 weeks they have to go to the nearest KK to do the ultrasound scan. So placenta growth factor. So what is placenta growth factor? So for those patients who actually have gestational hypertension or chronic hypertension during pregnancy, this is what we do in UK lah kan. This is from the UK guideline. I'm not sure the Malaysia guideline have this, but this is going to be very expensive if we were try to implement in our country. So the placenta growth factor basically predicts the occurrence of the preeclampsia. So let's say we are unsure that this patient who have gestational hypertension right now will develop into preeclampsia. So we send for placenta growth factor. The lower the placenta growth factor, the high probability that the patient will have the preeclampsia later in the pregnancy. So PrEP as prediction score is a score that we use to predict the complication of preeclampsia in 42 days. So uh, it's not widely used, but if you got your examiner with you and you know this PrEP as prediction score, it's actually good for you to mention and tell about it, maybe a little bit about it, where it's predict the complication of the preeclampsia in 42 days for this patient. Per se, you have a preeclampsia patient came to you at 30 weeks. So you calculate the PrEP as, so you can say that, okay, this patient if have high probability to develop complication of preeclampsia. So with this high probability, I would like to admit this patient. So that helps you in a sense of whether you wanted to admit this patient or just treated this patient as outpatient and see her in the clinic. So on regards of the medication, basically the antihypertensive medication that we give either for the gestational hypertension or preeclampsia, it's basically the same medication. You do give the labetalol, or if the patient cannot tolerate labetalol, you can give nifedipine or even levodopa. That's not a big problem. But for preeclampsia, when you have severe eclampsia, severe or we call impending eclampsia, you got to give the patient um, the pre-eclampsia prophylaxis. The eclampsia prophylaxis. So the pre-eclampsia prophylaxis tadi itu adalah the aspirin and also the calcium. So the eclampsia prophylaxis, when patient have impending eclampsia, you give the magnesium sulfate. So it can be given either in IV route or in IM route. It depends on the preference, but I think giving it IM is rather what do we call it? Give the suffering to the patient lah, because it's very painful and it's hot. So you got to give it 8 gram IM. So it should be given on the cheek of the buttocks. 4 gram on the left side and another 4 grams on the other side. So it's gonna be very painful. So you would like to give magnesium sulfate in sliding scale or in slow bolus 15 to 20 in 15 to 20 minutes. So the question is, when this is normally will be asked during your examination. So you have a preeclampsia patient datang, so your lecturer will ask, so you nak deliver this patient bila? Kan? Bila you nak deliver this patient? So for preeclampsia, we actually target to deliver this patient. Okay, per se preeclampsia alone, tak ada problem lain, tak ada apa-apa isu lain, semua okay. So we target to deliver sekurang-kurangnya more at term lah 37 weeks. Okay, so but then you got to have this patient, you have gone to the ward, you see some patient have like banyaknya masalah patient ni dengan ada placenta abruption lah, platelet tak okay lah, renal function teruk lah, then the apa ni, the umbilical doppler tak cantik, ada reverse end diastolic flow. So all these things are contributing to earlier than 37 weeks if the patient have these sort of things. So if the patient have to be delivered 37 weeks before 37 weeks, so you should have the idea of how to deliver a preterm baby. So a preterm baby, you should read on the other guidelines. But for the preeclampsia per se, the gist is what I want you to remember is it always deliver at time. Okay, tak kisahlah DM ke, hypertension ke, any other problem, kalau boleh kita nak deliver at term. But with some condition lah. Tak semualah you nak deliver at 37 weeks. Contohnya macam placenta previa ke, there's some condition yang boleh 37 weeks and there are some condition that cannot 37 weeks. So like that. Tapi what you should have, the idea is at least at term lah. Okay, unless otherwise ada issue lain. Right. So on the mode of the delivery, we don't have any sort of rule of thumb whether we wanted to deliver the patient either cesarean or in labor. But you need to understand that the labor process itself is very excruciating. It's very painful, provided that the blood pressure is already unstable. So it depends on the clinical setting where if you think that by giving patient a chance of spontaneous vaginal delivery, it's gonna be very painful and it's gonna actually makes the blood pressure unstable. Patient can go eclampsia if the blood pressure is not well controlled. Right. So it depends. So like I said earlier, you can actually opt for cesarean or assisted delivery for this patient. So for intrapartum, uh, what you should do, so you should monitor the blood pressure hourly. But if the patient go into severe hypertension, more than 160, you should be monitoring the blood pressure every 15 minutes. And you continue the anti-hypertensive medication as usual. And you should consider cesarean or assisted delivery in severe hypertension. Well, in practice, I would say that more patient go into cesarean because we don't want to risk the mother to attempt spontaneous vaginal delivery that the patient can go into eclampsia on the labor room and eventually have to undergo emergency cesarean where in emergency cesarean there would be a lot of more complication. The patient can succumb to aspiration pneumonia and a lot of other risk factor that the patient have go through. So usually it has to be discussed first with the patient and most of the time cesarean section is preferred. But this is like preferred for a doctor lah. Tapi in the guideline, it is basically a shared decision. Okay, because you have to consider if kalau kita scissor this patient, most child yang they will have is 4 kan. So let's say the patient is primary gravida, ada preeclampsia, and then you straight away nak decide for the patient cesarean section. I think it's not actually justified. So you have to go clinically whether memang betul-betul kena cesarean atau tak. Bukan your decision, I say. So post delivery management. So bila in your exam, bila prof tanya how do you manage this patient, so kalau case-case macam preeclampsia ni, you should be saying, so I would like to manage this patient antenatally, intrapartumly and postpartumly. Okay, sebab condition in either gestational hypertension, gestational DM or preeclampsia, we have to do a surveillance post-delivery. So for example, in this case, the blood pressure monitoring, what you should do is blood pressure you should do apa 4 kali uh, 4 times per day, so 6 hourly lah until discharge. Lepas tu you do daily from day 3 to day 5. So mean usually our patient discharge at day 2 lah kalau tak ada apa-apa issue. Day 2 usually after 12 to 24 hour post delivery patient dah boleh discharge. So the day 3 and day 5 ni is when patient you have to do notification to the nearest KK lah. Maksudnya patient will come to the KK and do blood monitoring daily, day 3, day 4, day 5. Okay, kalau if the BP normalize, okay lah, dah boleh stop. So nanti tengok after 2 weeks. If not, you should do every other day lah. Contoh day 5 dah buat, so nanti kita akan tengok day 7, day 9, day 11 dengan day 14 untuk kita review after 2 weeks. So kita buat until the blood pressure is normalized. So we continue the medication for at least 2 weeks. So but some condition lah, meaning if you have methyl dopa, stop methyl dopa. Methyl dopa cannot be used until postpartum. So if you do give methyl dopa postpartum, you will increase the risk of postpartum depression, postpartum blue to the mother. So you change into labetalol ke, nifedipine ke, or even you can actually give enalapril pun boleh. But do not give like macam diuretics, and also another one is ARB. ARB and diuretics is cannot be given lah post delivery. So you should give sama ada labetalol ke nifedipine, tak apa, you just continue pun tak apa, tak payah tukar ubat lah. The thing yang you have to tukar ubat usually patient yang ada chronic hypertension. For example, before the pregnancy, diorang memang makan ACE inhibitor, enalapril per se. So when post delivery, you can convert back into enalapril macam tu. But tapi kalau nak senang ingat waktu exam tak apa, kalau dah patient ambil labetalol, just continue with the labetalol, no problem. So and then the next question is bila you nak kurangkan kan dose. So we reduce the medication if BP below 130/80 lah. We should tail down, never off. Jangan terus off. For example, you give labetalol 20, kurangkanlah sikit-sikit until off lah. So after 6 weeks of delivery, you should review again whether this is actually pre-eclampsia ataupun memang actually this patient have hypertension, because there are some degree or portion which they have persistent high blood pressure and they become hypertension after delivery. So kalau macam tu, just continue medication lah, treated as medically lah. So when to discharge? Okay, bila you do the report round, so nanti doktor tanyalah, so patient ni bila kita nak discharge? So to discharge patient who have preeclampsia, first, there are no symptom of preeclampsia. No headache, no severe gastric pain, no pulmonary edema, no clonus, no hyperreflexia, no, that's one you can discharge. And then blood pressure starting to stable, which is with or without treatment is less than 150/100. So with that you can discharge. Tak ada symptom, blood pressure dah bawah 150, which is you can still continue medication at home, so boleh discharge. The other one is if the blood tests are stable in improving. Contohnya macam patient no longer thrombocytopenic, LFT semua dah, transaminases semua dah getting back to the normal, not necessarily normal, baru you discharge, because it took some time. For example, kalau patient thrombocytopenic, maybe it took like 3 to 4, 5 days untuk the patient get into the normal baseline. But unless it's improving, so you can discharge, but you got to notify the KK to review the, maksudnya okay, contoh you nak discharge day 2, thrombocytopenia dah okay tapi belum normal, maksudnya platelet 120. Normal kan 150 to 450. So belum normal lagi. Takkan you nak cap the patient until normal, it's gonna take few days kan. So what ramai patient. So you discharge but you notify, contoh okay KK balik, you have to monitor lah patient ni full blood count maybe day 5 ke day 7 untuk look back whether it's getting better or it's improving or not lah. Okay, so kita dah habis preeclampsia. So this is some little bit of eclampsia alone. So eclampsia itself is obstetric emergency. So kalau your lecturer asks during your exam during your CP, how do you manage this case? First of all, you have to say this is an obstetric emergency. So that would be your opening statement. This is an obstetric emergency. I would like to call for help, calling my senior, calling the obstetrician, and inform anesthetic and the pediatrics. So because, for example, patient 32 weeks kena eclampsia and you thinking of deliver, so we need an NICU backup. We need pediatrician to datang lah. So this is basically the management. Place patient in left lateral position, airway, breathing, circulation, put CBD, monitor vital sign. Okay, for anticonvulsion, kita tak bagi diazepam lah. Okay, always magnesium sulfate unless contraindicated. Maksudnya contoh, patient ni memang epilepsy. So dia kena convulsion ni, we are not sure whether this is because eclampsia ke ataupun memang this patient memang known to have the epilepsy. So in that case, diazepam is justified. But in other case where this patient have not known to have any epileptic syndrome or whatsoever, always use magnesium sulfate. Okay, so you got to control the hypertension, consider delivery and the postpartum management. So this is magnesium sulfate. It acts as cerebral vasodilator. It's different with diazepam or lorazepam. Diazepam and lorazepam, it reduce the cerebral uh, firing and neurotransmission. So magnesium sulfate is act as cerebral vasodilator. That's all. So if we give magnesium sulfate overdose, so what we have to monitor is respiratory depression and also cardiac arrest. So in this patient, you should monitor lah. Ada maybe do the tengok the heart rate and also you have to count the respiratory rate because patient can have the respiratory depression. So what you should monitor is when patient have magnesium sulfate, patient akan have loss of deep tendon reflex, respiratory depression rate tu tadi I've already told you, dia renal impairment. No. Okay, remember that magnesium sulfate, intoxication of magnesium sulfate, it does not give renal impairment per se. But why you need to monitor hourly urine output? Because the excretion of magnesium sulfate is through urine. So if the patient have some degree of renal impairment, you will have a lot of accumulation of magnesium sulfate in the circulation, which lead to the side effects or toxicity of the magnesium sulfate. So that's why you need to monitor the renal function. So by looking at the hourly urine output. So the antidote for the magnesium sulfate is calcium gluconate. So this is what I've said earlier. The regime that we have, IV or IM injection. So usually we go for IV. So less excruciating lah to the patient and kita boleh guna sliding scale through control infusion pump. So boleh bagi pelan-pelan. So if you look on the IM injection ni kan, kena bagi 5 gram to upper quadrant of each buttock. So sebelah kanan, sebelah kiri you have to give 5 gram. It's painful kan sebab it's IM. And then you should give a maintenance dose 4 hourly. You can you imagine every 4 hourly you have to be inject banyak kali kan. So it's going to be very painful. So just use IV lah senang. Unless patient datang tak ada line, datang ke PAC dah eclamptic. So daripada you nak yelah patient eclamptic, kena seizure, it's not easy for you to set the line. So in that case, IM injection is preferred lah. So boleh lah waktu tu you nak inject IM je kan, sebab line tak masuk lagi. Right, so there is a pump. So this is when magnesium sulfate is contraindicated. So I don't think you need to, yelah cuma tahu, it's good to know that we can actually use diazepam if magnesium sulfate is contraindicated. That's all. So control of hypertension, this is I've already told you in preeclampsia, uh, but also in eclampsia, this is one of the uh, medication. Kalau in preeclampsia medication alone, usually you just give oral lah, oral levetolol or oral nifedipine. So if patient have eclampsia, you will change your medication into IV hydralazine or IV levetolol. So untuk cepatkan reduction of the hypertension. So diuretics are contraindicated. Yes, it's contraindicated and you can see it in the CTG hypertension lah, memang kita tak gunakan. So just stick into nifedipine, labetalol and also metal dopa. Kalau yang teruk sikit ni kita bagi hydralazine. Tu je lah. So this is the medication and the dose. This is not really important in your level. So nanti dah kerja kot baru this is important. If you ask me per se, I did not remember pun. Okay. So this is urgent delivery for eclampsia. So there are several conditions where patient ada eclampsia, you should terus deliver. But not necessarily. Contohnya, if patient have eclampsia, and then BP normalize, BP makin okay, below 140, tak, CTG normal, CTG reactive, tak ada issue, patient still pass urine normally. So it's actually not indicated for urgent delivery. This is kalau patient dah term 37, it's okay for you to patient eclampsia and then walaupun terus boleh deliver. But the problem is why there is some indication, because if patient 34 weeks not fulfill the indication, so no need for urgent delivery, because if you deliver, you will make the baby have to live in a preterm condition. The baby will have to, you increase the risk of preterm condition, which is cerebral palsy, infection and whatnot lah. So if there is no indication, although patient have eclamptic seizure, not necessarily to have delivery. Okay, delivery often by cesarean section, vaginal delivery is possible. So like I said earlier, there's no general rule of thumb whether you want to decide for cesarean section or vaginal delivery, but like I said earlier, because in cesarean section where patient is intubated or under anesthetic, it's easier for us to control the blood pressure. So kalau blood pressure tinggi, we just top up the ubat, or kalau rendah, we just top up some medication to control the blood pressure. So this is postpartum management. Eclampsia usually resolve within few hours. You got to give the magnesium sulfate at least 24 to 48 hours, and if there is another seizure or eclamptic fit postpartumly, you should actually continue magnesium sulfate 24 hours from the last fit. Okay, katakan dia pukul 12 tengah hari, dia ada fit, so you bagilah lagi 24 hour tu, 24 to 48 hours. Habis tiba-tiba ada fit lagi, bagi lagi. Okay, dose of antihypertensive should be tailed down gradually and should not be stopped suddenly lah, because it will provoke again eclampsia punya seizure. Okay, I think that's all from me. These are the reference. Okay. If you have any question, boleh tanya lah. Okay, ada nak tanya apa-apa? Tanya ke, discuss ke, you know, you're not with your lecturer, I'm not your lecturer, I'm just sharing what I've been learning through my medical schools and the thing that you will learning as well. So kalau nak tanya apa-apa, just go on tanya.
Doktor, I would like to ask regarding yang doktor terangkan yang when to discharge patient tu kan, yang first to look at the symptom of preeclampsia dengan BP semua tu. So basically kalau patient tu macam kita tak semestinya kena tengok these three criteria tu dah macam fulfill lah, boleh discharge. Kalau either one dah fulfill, dah boleh discharge lah. Tapi kita refer dekat kita ke macam ni? Yang doktor terangkan.
Discharge the patient, you should actually fulfill those three criteria because you have to look into, contoh, the BP is below 150, it's one of the criteria, BP is stable. Tapi patient masih ada pre-eclampsia punya symptom kan, contoh macam ada severe headache, you wouldn't dare untuk discharge the patient because walaupun BP dia nampak macam stabil, 140, 90, 144, 96, but with the pre-eclampsia symptom, kalau you discharge, buatnya dia ada eclampsia dekat rumah, so that would be problem lah kan. So it's best untuk fulfill all the three criteria. That's the criteria. Okay, usually nanti kalau you ada round dengan Dr. Azhar ataupun Dr.
I think there's no question for doktor.
Okay, kalau tak ada question, I think that's all from me. If you got any question later on, ataupun if any of my shortcomings that you did not understand, you can ask your lecturer. And I think that's all from me. Thank you.